Over to you, Doctor.
Okay, thank you. Today, like if you attended last class lecture on balloon dilatation of BPV, we had left few parts about the balloon ruptures, where I will try to cover that part today also. And today I will be talking about some tips for the balloon dilatation, neonatal coarctation of aorta. Okay. So, starting with the diagnosis of coarctation fetal life. So this is important to learn and understand that this can be diagnosed nowadays. And the main two criteria are RV-LV ratio in fetal life. Like you see, the RV and LV ratio can be taken. And if it's more than 1.3, 1.4, depending on gestational age, you start thinking or suspecting coarctation. And then isthmus ductus ratio in triple vessel view. This triple vessel view, ascending aorta to descending aorta, this is isthmus. This is ductus from PA to descending aorta. So ID ratio can be taken, and if it's less than 0.7, it's the highly sensitive marker for the fetal cohort. This was the 22-week fetal female, 22 weeks old. So let's learn this part. Three vessel view, normal versus abnormal part, where aorta is much smaller than PA, and LSVC is an important marker for the coarctation also. So see this normal triple vessel view. I have PAS. So P and A are almost similar. P is slightly bigger. Now here, patient of fetal coarctation. See the PA is much bigger than aorta, and you can see in LSVC also. So presence of LSVC, I will show you one more image for the LSVC. So this part. This is the LSVC, you can see. And RV-LV ratio, you can see the significantly raised RV ratio, LV ratio is more than 1.5, and you can see LSVC. So when you see RV-LV ratio discordant with the LSVC and isthmus ductus ratio, then you can suspect this is a normal four-chamber view, and this is a normal four-chamber view. So you can see the difference between RV-LV ratio and LSVC. The fetal coarctation it should be diagnosed nowadays, and we should not miss it. Okay, now we'll come to the neonatal coarct. Just a brief about neonatal coarct. You have to assess the arch along with coarctation and rule out Schwann's features. Always document tricuspid aortic valve or bicuspid aortic valve, and also two pap muscles. Very important. Now this is the patient, which was slightly interesting, so I'm sharing with you. Neonate in shock, presented to shock around 7 days of life. All 4 limb pulses were feeble, and there was no differential pulse. Echo was LVEF 10%, and no gradient arch. So this was a confusing picture for us, that I don't have any gradient. All 4 limb pulses were feeble, 4 limb pulses. So I was not sure what is happening, but when I put my hand on the carotids, they were bounding. So we knew that something is wrong here, and let's go to the cath lab. In the cath lab, what we found? So aberrant right subclavian and left subclavian also coming out from the coarct segment. So all subclavians and descending aorta is arising below the coarct, because aberrancy and left subclavian just at the mouth of coarct. So that's why all 4 limb pulses were not palpable, but carotids were bonding. So when you see a patient in shock and you're not able to find any pulse, always check for the carotid also. So sometimes can be deceiving, and also look for URSA and coarct when you're checking a patient of LV dysfunction. URSA and left subclavian artery anomalies can lead to miss the diagnosis of coarctation. This we presented. So URSA and this was published a long time back, around 2011. But remember this part on the echo, that you have to look for URSA and always look for carotids. Now, indications of balloon coarct are very simple. I think we all know about these indications. Age beyond 3 months, native discrete coarct of aorta without arch involvement. Age beyond 3 months, indication of balloon coarct. Recurrent coarctal surgery or intervention, we all know this. And less than 3 months of age, if it's palliation, because you need palliative surgery, because like surgery is high risk or severe LV dysfunction. Nowadays, a lot of surgeons are comfortable with the LVEF for more than 30% to go for surgery. So in our unit, if its LVEF is less than 30%, only then we go for a balloon dilatation, otherwise not. Now this is few of the standard parts I'm revising, then we'll go to the specific parts. Always do hemodynamic measurements, autogram in all cases. Autogram is must in all cases to assess the arch. If you're very good in echo and you're seeing good echo images, then maybe you can avoid. But we say arch should be assessed when you're planning for a balloon cord, because you can understand the recurrence and plan for surgical repair in future also. Always measure proximal transverse arch, distal transverse arch, isthmus, minimum diameter of quart, aorta below, just below the quart, and descending on diaphragm to assess the size of what size of balloon you want to take. You need to take all this into consideration. Proximal arch is distal to first branch, distal arch is between first and second branch, and isthmus is beyond the third branch. So these measurements should always be taken in all cases of balloon dilatation, mostly by angiogram or by echo. Contrast material, again, this was done in the last class also. In smaller balloons, 1:3 ratio, otherwise you will not be able to see the balloon actually. So 1:4 or 1:5 dilutions, balloon is not seen very small balloons. Balloon inflation up to 10 seconds, 20 seconds, and deflation as quickly as possible. Selection of balloon catheter. This one, you remember these two parts, and then I will come to the balloon dilatation selection in future slides also. Balloon diameter should not exceed aorta above the coarctation. So just above the coarctation of aorta, it should not exceed the arch or at the level of diaphragm. So it should not exceed arch above the quart and at the level of diaphragm. Which is smaller, you should use the balloon that part. It should not exceed 3 times the diameter of quart segment. Otherwise, you increase the risk of rupture. So, two criteria you should keep in mind: not exceeding 3 times the minimum diameter and not exceeding diaphragm measurements at the level of diaphragm measurement and above the quart segment measurement. Now, remember this thing: low profile balloon catheter should be used so as to use minimal sheath size. And mostly younger children, you can have low pressure balloons, whereas older children, you may need high pressure balloons, and especially with the recurrent cohort. Normally, in recurrent cohort, we tend to use higher pressure balloons. And also, few studies have quoted that in newborn also, especially in the recurrence, suppose you have done the balloon at 2 months and recur as 4 months, you can do a partial inflation with high pressure like coronary balloons of size of 4 and 5, and then you go for the other balloons, upgrading the balloons. So high pressure coronary balloons can be used in smaller children to inflate at the same size of quart segment, just 1 millimeter extra of the quart segment to inflate the narrow segment. Target in isolated cohort, grade less than 20. Univentricular heart, if you are doing balloon, try to target less than 10 mmHg, so they may have risk of high afterload. And you should try to increase the luminal diameter of aorta at the level of cohort. But you understand that you can't achieve the level of pre and post cohort diameters. Post cohort, is very much dilated because of post dilatation. Pre cohort, you cannot reach. So you should try to get luminal diameter high, but not at the level of, not target that part. This is really interesting. How can you approach a coax segment? Most commonly, we use femoral artery. Then the other routes are axillary or brachial artery, then carotid artery, femoral venous umbilical artery. I will go all through these routes one by one, and let's see what are the relative advantages and disadvantages. Femoral artery, we all commonly use it. Nowadays, in our unit, neonatal critical cohort, normally we do USG guided, though advantages are there actually. Extreme preterms. Extreme preterms, you remember, even 4 French teeth may not be possible. So we had a case like 1.5 kg, 1.4 kg preterm, and we were thinking of the critical case, so we were thinking of balloon dilatation. We could not get the femoral artery, so we called the surgeon for cut down. But after cut down, we saw the femoral artery was only 1 millimeter size. Even you could not put, even 4 French was not able to push into the femoral artery. So then, this was a long time back, and I was not doing axillary and carotid in those stages. So we sent the patient for surgical repair. But remember, In extreme preterms, which are less than 1.5 kg, even 4 French teeth may not go. In such cases, we do nowadays with axillary artery route. Axillary artery and carotid artery is very bigger than the femoral artery in coarctation. In coarctation, as a rule, lower limb arteries are smaller. So descending aorta, beyond with bifurcation, femoral arteries, iliac arteries, they're all smaller in size compared to other kids. So if you have you're dealing with extreme preterm and you want to use artery, maybe axillary artery may be a better idea because very small preterms you may not be able to put even 4 French teeth. Then also remember, in a smaller child with femoral artery, thrombus and limb threatening is possible. In such cases, thrombolysis should be considered. Now, a lot of units will not do this thrombolysis if the pulses are palpable or weakly palpable, limb is not threatened. But what we have realized that they keep coming back to you. Coarctation patient will come back to you. So if you lose one artery, you may not be able to access the same artery route next time. So in our unit, nowadays, we are practicing thrombolysis. If you're not, we're seeing a documenting a thrombus, which is occluding the femoral artery. We use heparin for 24 hours, and next day we'll start the thrombolysis with deltaplex if it's not responding to heparin. But we don't leave the patient with the thrombus on ultrasound scene. Though I understand collateralization happens, but I need to use femoral artery in future. Coarctation, most of the time coarctation, bicuspid aortic or something, they will come back with recurrence. So I would like to have a patent femoral artery at any cost. Now see this patient and try to find the basic mistakes in this scenario. So this we did the femoral artery injection, site of coarct, and then did the balloon. Balloon inflated. The two major problems here are I have not seen the arch here. I have not defined the arch. And I have balloon dilution is contrast dilution is too much that I'm not sure what is happening here. So you should try to define arch so that you know what is expected in the next few months. And contrast dilution should be better so that you can see the waist and you can take a call on the size of balloon. Now, what of the axillary axis? So I don't know how many it's using the axillary axis as a primary route of coarct, but I will tell you a few examples of axillary axis, then we'll talk about advantages. This is the patient of, see this very beautiful angio. It's a sheath, 4 French sheath from the axilla, and you can profile the whole of the arch in one go without causing any trouble here. And then balloon. The visualization of arch and quartz cement is so easy, and it's just a hand injection by a 4 French sheath, some 3 ml, 4 ml contrast. So you're very close, you're going antegrade, the visualization is very good here. Advantages, axillary artery is not an end artery. See, femoral artery is end artery. If you have thrombus in the femoral artery, you may have limb threatening. But axillary artery is not an end artery. Arm and forearm are perfused by acromion branch and second intercostal branch. Then axillary artery is better palpable compared to femoral artery in coarct. You know this, upper limb pulsar palpable, axillary artery bounding. So the access, the palpability is so good that you feel the axilla and you can easily puncture without using guidance. Femoral access in small infants may be leading to vascular injury because of an artery. Now, compared to carotid artery is also cumbersome. Mostly is done by a surgical cut down method and the risk of fatal thromboembolism and carotid stenosis. You are near to the brain. So carotid artery access is also not a favorable phenomenon if you can get axillary artery. Assessment of arch and coarctation segment relatively easy with axillary approach by hand injection, especially difficult to cross lesions. The contrast requirement is very less and difficult to cross lesions are very easy to. I will show you one example of difficult to cross lesion. See this patient. A tiny flow. I came through axilla, tiny flow. Now, if you go from down, you have higher chance that you're going to damage this. So difficult to cross lesions, better to go from up. Now, how do you know what is the difficult to cross lesion? By echo also maybe you can have understanding. And then this balloon dilation. Simple process actually. See the contrast dilution here is adequate, 1:3. So difficult to cross lesions, I would go by axillary route. Now, so this is our paper on axillary arterial access for balloon dilatation of coarctation. Cardiology is a young year 2021. We had done around 5 cases of balloon dilatation by axillary artery access as a case series, and we did not find any trouble actually. The access time was always less than 3 attempts for the axillary artery access. None of them had limb ischemia, limb issues. On follow-up Doppler, none had thrombus because the axillary artery is much bigger than a 4 French sheath. And you don't need more than 4 in a newborn. So what we recommend nowadays we do is primarily we go by axillary artery access, or we don't go by femoral artery access in balloon dilatation of coarctation if it's a newborn child. If it's less than 3-month-old child, we're doing balloon, the axillary artery access is the primary route in our unit. The advantages I have told you. Let's see this advantages. Not an artery. That is the best advantage. Better palpable. Now, carotid route. Carotid route, we do it occasionally. This is not my study. Some APC published in 2020, called TB. Percutaneous carotid access. I was interested in percutaneous access. They did the percutaneous access, USG guided, in left carotid access percutaneously. And they found a particular importance of carotid access in preductal coarcts. This coarct is, duct is here and coarct is here. So when they were coming from femoral artery, the wire was going into the ductus and they were not able to cross to the critical coarct segment. But from up, they could easily balloon it. So maybe this may be the scenario where you want to go antegrade. But again, if you go for axillary route, you may be easier actually. So this series particularly was talking about percutaneous carotid access. Total patient 33, total cath by carotid 36, balloon coarct in 4 patients. The complication they found was no neurological insult. 2 cases had non-occlusive thrombus. One has mild narrowing, one has pseudoaneurysm, one has large hematoma. So not much complications in such patients also. All were newborns. So they said that this is feasible. We don't use it. We have done till now is cut downs, but USG guide may be a option by percutaneous route that we can have learning skill. But if axilla is available, still I will rate axilla as a better route because it is always percutaneous and not away from the brain side. Now, femoral venous route. It's also interesting to know that femoral venous route can be used in newborns by the PFO or transeptal puncture in the older children. Basically, circuitry is code. You know, see this, the femoral artery route that you have to go by femoral artery. Try to learn this path that you have to go by femoral vein, PFO, mitral valve, aorta, and then carotid. So it's a circuitous route, and it's difficult to reach to the quad segment. But especially in a preterm child, 1.5 kg, 1.2 kg child, it's very good actually because you're not using the artery. You know, I told you that like I long time back I had a preterm child. I could not get the femoral artery access, and femoral vein may be a better option in such cases. But you know, you may not be able to cross catheter or balloon. And avoid the mitral valve damage, aortic valve damage. Just take care that you're not pushing or pulling across the aortic valve. And especially it's useful in single ventricle patients because route is maybe more straightforward. You may not have that much route circuits depending on anatomy. Now this is an old patient of us. It's an old cath lab, so imaging is not very great. But see, this guiding was put across the femoral vein, and then coronary balloon was deployed. And here we were not able to cross again the second curve, so we kept a two-wire study, two-wire technique to use this balloon crossing. So one wire was kept in the carotid, and the other wire we could cross to the descending water like this, and then balloon could be done. So guiding, five French guiding is a very good method to use the two balloon technique, two wire technique actually. This one we don't commonly use. I personally feel in extremely preterm child, where you are reaching less than 1.4 kg, femoral vein may be a good idea. Try to use guiding here, but you will need two wires most of the times. So this was the same patient guiding two wires, one in the carotid, and then we could do the balloon dilatation. Which is not good because it was an old cath lab, very old cath lab, around 15 years back. So this balloon could be done. Now, so femoral artery route, carotid artery route, femoral venous route, umbilical artery route. Though I have not done umbilical artery route for the coarct, but it's feasible as you understand. Most of the time, what is happening is coarct manifests after 3 to 4 days. That's why, and then you may not be able to have umbilical access. So most of the times it's not used. But understand this, umbilical artery route is tortuous. That's why you may have some troubles in going through, but most of the times, once you pass this part, you should reach the coarctation side. So it should not be difficult to reach to the coart side once you get it. I have not done it, but literature has shown some case reports. This is umbilical artery route, which we can use to balloon dilate the coarctation. Now, some hints about balloon dilatation. So, this was about the roots. Now, I'll put some hints about the balloon dilatation. So, if crossing from the femoral artery is difficult or impossible, try to cross from above. But I use nowadays in our unit in newborns, we use axillary route. Our preference axillary route. We found is very easy and very safe. Always keep a arterial monitor in the lower limb if possible, if you're going to femoral artery route, to assess the immediate results. Rapid RV pacing, we don't use it commonly, but sometimes if balloon is not stable in older patients, you may use it. In deflator versus manual, in smaller balloons, low pressure balloons, manual is acceptable. Don't use more than 5 ml syringe. For 5 ml syringe, you can't generate so much of pressure to balloon rupture. Then also avoid manipulation in the dilated area. Once you dilate the area of coarct, then you don't manipulate that area or trying to recross, because the newborns, you may rupture the dilated area, you may cause balloon rupture, the arch rupture or the cord segment rupture. So don't manipulate this, recross it immediately after. So don't lose the wire. And if you lost the wire, avoid recrossing this. So manual inflation, remember 5 ml, avoid manipulation, and try to use auxiliary access. Sometimes with large collaterals in newborns, the wires may pass through the collateral. So remember that part also. The newborns may have large collaterals, you may pass into collaterals. So be sure that you are in the right area before balloon dilatation. The limitation, marked arch hypoplasia. Transverse arch hypoplasia should be referred for a surgery. A few of the complications I will try to discuss with you all. One of them is aortic wall dissection. One is aneurysm, then neurological insult, arterial damage, and ruptured balloon. Five main complications with the coarctation. We'll should learn how to handle these complications one by one. I will discuss this part. Aortic wall dissection. It's rare, but feared. When this happens, you are in trouble. Most common reason is balloon size. Because balloon size is relatively subjective. The multiple methods are used for balloon sizing. And they know detailed comparison of various methods, like how do you decide a balloon size? There are 3 methods a lot of people use, but they know comparison available, which is better, which can avoid the aortic dissection. So One of the methods is double the area of quad segment. You double the area of quad segment, but don't exceed the dimension at the level of diaphragm. Is one method. I think a lot of units use this area of not exceeding the diaphragm aorta. Second method is within 2 millimeter of diameter of aorta at the level of left superior artery. That means proximal distal arch basically, but not greater than the diaphragm artery. So you will not cross 2 millimeter above the left superior artery area and not crossing the diaphragm diameter, whichever is smaller you use. Then third group is the diameter at the level of diaphragmatic aorta, irrespective of the dimension. There are three methods. There is no comparison available. Now we remember initial balloon diameter at least twice has to be there of the quad segment to achieve reasonable results. So you have to be, if the quad segment is very narrow, at least twice you have to balloon dilate to have some reasonable results. Now, if a quad is very tight, I showed you one case of quad, very tight quad. There you can't go more than 3 to 4 times the minimal diameter, irrespective of the diameter. So remember, try to at least 2 times and not more than 4 times the minimum diameter. And don't go above diaphragmatic aorta, and also don't go above the 1 to 2 millimeter of the proximal distal arch. Don't go above 1 millimeter of the distal arch. You will avoid these parts, and mostly you will avoid the dissection. Then also remember, sometimes a wire is placed into carotid arteries or superior artery. That you should avoid. So this can lead to vascular disruption during balloon fasting. Vascular disruption of smaller vessel is possible. Avoid wires and catheters in the carotid or superior arteries. And avoid exceeding the diameter pressures of the recommended pressure, because once balloon rupture, it can increase the risk of aortic valve damage by the balloon rupture. In the newborns, it's very much possible. So try not to rupture the balloon. Don't go above the maximum inflation pressures. In the newborns, try to avoid reuse of balloons. Don't reuse the balloons in coarctation. Newborns. If there is a significant aortic valve rupture, what to do? Maintain calm. No, for any interventional pediatric cardiologist, this is the most important part. I will tell you from my experience, whenever I'm in a hurry, I make mistakes. When I'm angry for necessary clutter things, I am making mistake in calculus. So don't do these things. Whether there's a complication or not complication, don't get excited. Don't shout. Keep your mind calm. Don't lose wire position and inform CTBS. First step is don't lose wire position, inform CTBS. Check for hemothorax and chest tube most of the times, and blood can be auto-transfused. Always here, no, in newborn coact, blood transfusion unit should be ready. One blood bag should be ready, always. Balloon inflation can be done at the site of rupture to prevent blood loss. Some softly balloon can be to give the mechanical compression of the rupture. You may do that. Best method would be covered stent if it's available in your, depending on age. But covered stents, most of the times, coronary covered stents are available at 4.5 size. The newborns can be managed with covered stent, coronary covered stents. They are available in most of cath labs. Number 2, complications, aneurysm. Small aneurysm, follow the progress by CT or MRI. Most of the times, next 24 hours, you should know what is happening to the child. If size is rising, or there is spiral aneurysm happening like this, stent. Now, larger aneurysms, if on the beginning there is large aneurysm, covered stent or surgical repair is the method. Don't wait for 24 hours. Now, once the small aneurysm has happened, you have to follow them indefinitely, because even after 5 years, you can have a size rising after 5 years also. So you have to keep following the aneurysms for a long time, maybe lifelong. So aneurysms, large aneurysms, covered stent, or if not covered available, you can use a bare stent also to get a time. Small aneurysms follow. This is the patient, interesting patient actually. Preterm, 30 weeker, 1.2 kg child. Surgery was done at our institute. Discharge after 45 days. Long time stay, BPD, prematurity, something happened, feeding issues. At 3 month age, recoarc. Now child is 1.8 kg. Balloon attempt was done outside. This is the NG of the balloon attempt. And after balloon, see, after balloon, there is a rupture. This is the some leak from the descending artery. Now, this is the echo. When the patient came to us, echo. This is the arch, and you can see it's large and so there are two options here. Either we put a cover stand, or if you have surgical backup available, you do for a surgical. You can see this echo also. You can see large and I don't know what balloon size was taken, but this is a possibility with any of us. So be ready with these complications. Our surgical team is aggressive in managing the patient. So when the patient was surgical repair, we try to avoid stents in all newborns. Actually, we rarely put a stent in arch newborns. I don't remember putting a stent in a newborn child. So otherwise, if surgical backup is not there, you will need a covered stent here. This is from the net, and after balloon dilatation, and then covered stent was put. So it looks like a bigger child actually. So covered stent is also a possibility. Now, complication 3, neurological insult. Mostly thromboembolism happens then, and most of the time because you're dealing in the area of neuropart, carotid arteries, supplemental arteries. So you are in the area of cerebral circulation that is leading to thromboembolism. Most important part would be anticoagulation. Maintain the ACT in the range of 200 to 50 seconds. And also about this ACT part, I don't know if you do it ACT or not. In our unit, we do a baseline ACT, and then after heparin, we use the ACT. And in newborns, most of the time, this level is achieved by 50 units per kg, and not by 100. So we start with 50, and then we go ahead with the, if you need more, I will use the more heparin after ACT checkup. So we do baseline ACT, and then sometimes even 100 units, lot of units practice 100 units per kg heparin, one bolus, and this has gone to 500 also. So try avoiding that part. So you're puncturing the artery, and you may get an insult to the artery. Complication 4 is, complication 4 is ruptured balloon. Now, obviously you have to retrieve the balloon. The ruptured balloon it can be retrieved easily. You remove through the sheath. No issues. Check the balloon fragments. Everything is okay or not. That's all. But if can't be removed through the sheath, then you remove the sheath, groin sheath, and catheter as a single unit, combined sheath, and you can. But you may damage the vessel. If balloon catheter cannot be removed through the sheath, then cut the, like this is the balloon, this is the shaft. You cut this shaft, keep the wire in, above the wire, put a bigger sheath here, and then try to pull it. So exchange with a larger sheath. After separating the lower connector, separate the lower connector is possible till the catheter, and then you can allow the balloon for putting the larger sheath. That is one idea of removing the ruptured balloon. Then always inspect the balloon for full segments, that we have taken all the fragments. So balloon material is not really opaque. The fluoroscope will not be helpful. You have to do the ultrasound or echo to find the localized and then remove the snare. Most of the times, luckily, the rupture happens vertically and it clinges to the wire. Or even if it's circumferential, it clings to the wire. So it doesn't go out most of the time. I have not come across where I have lost the balloon segment. Rupture of balloons is possible, mostly with the reuse of balloons. Types of balloon rupture. This is longitudinal segment rupture. Most common longitudinal rupture can be retrieved entirely. We know this. This we have all seen. But these types of rupture, where the one part circumferential rupture, are uncommon but possible. And these fragments can stay inside. How to take this out? We have to learn. Let's see how do you take these fragments out. So this one circumferential balloon rupture. To retrieve the circumferential balloons, let's see, we're going through one artery. This is circumferential rupture of the balloon. What do? Snare this wire. Snare this wire. So contralateral artery and snare the distal end of wire. And then proximal part is taken out and cut. An MP catheter is pushed. Now I'm pushing the MP catheter so that this distal segment, which is snared already, will go into this part. So like this, MP catheter is pushing the distal balloon segment into the contralateral sheath. So the other tip is in control with the snare. You take it from the artery. This is important. Keep this in mind that if the circumferential rupture has happened, don't lose the wire. Snare this wire and then push. This the proximal part is taken out. Push the MP. Remove this the shaft. This is a very worrisome situation, but this is a simple solution. Complication 5, vascular injury. This patient, like we had a coax surgery at 2009. This patient was real patient of us. Day of life 7 days, RFA cut down for surgical repair. This RFA cut down was done. Then at 2 months recurrence. Now RFA is not available. LF access was done. So now we have used both arteries. So you remember this was 2009. In 2011, came with the recurrence third time. You do again balloon, but at this time we could puncture the left femoral artery with difficult USG guide access. Now, the child is 2 years old and we have lost already, we don't have access, proper access on the both sides of femoral artery. In this situation, the axillary artery would have been a better choice. But in those days, I was not using the other access. So now, that's why I'm focusing that please try to use other access routes also. Now see this patient's angio. Sheath injection through the artery. And see the size of femoral arteries. 2-year-old child. You want to do balloon this part. What is the size of the femoral artery? 5 French were not going. So we could partially put the 4 French sheath. PTCA balloon with Taishak was done. I could not go beyond this due to exercise issues. This could have been prevented if we know how to preserve the femoral arteries. And that's why role of thrombolysis. Role of thrombolysis. Don't leave thrombus in the femoral artery, especially in aortic valve disease on the left side obstructive lesions, because they will come back to you. So read few studies about alteplase. Alteplase is available. We on our unit have started using alteplase, and we have found very good results. Most of the time, single dose of alteplase or maybe maximum 2 doses of alteplase, and we get the good thrombus removal. Now, restenosis is also we understand balloon clot as a restenosis. This interesting study we found by Dr. Rao, P.S. Rao, say in 1995, he tried to assess what are the risk factors in predicting recoarctation. So it was a multivariate regression analysis was used, and they found age less than 12 months, size of aortic isthmus less than 2/3 of the ascending aorta. That means just before the first branch. And size of coax segment. If it's less than 0.3, 0.5 mm pre-angioplasty and post-angioplasty less than 6 mm, you have higher chance of recoart. And this was a 37 infants, age 2 days to 15 years. Wide range. That's why this diameters may not hold true. Because in a 14-year-old child, you may have 6 mm, but in newborn you may not have a 6 mm diameter. So, but few parts, smaller post-angioplasty diameters, smaller pre-incisional diameter, size of aortic isthmus being very small, you're in the risk of recoat. So, summarizing the complications: aortic wall dissection, small dissection, follow-up, large dissection, stent, small aneurysm, follow-up, large dissection, large aneurysms, covered stent, or surgery. Neurological injury, avoid vas, the carotid artery, femoral artery damage or the arterial damage, thrombolysis or surgical repair. Ruptured balloon, retrieve. Remember techniques of retrieval of the balloons. A few two slides about stents. It's not a topic today, but remember, stent can be put in exceptionally situation where you don't have a backup of surgeon, you have gone to rupture. So people are trying to have breaking stents or growing stents basically. And that you have to understand. There are few case reports where people are finding out breaking stents or growing stents. Now, in the current scenario, you are worried about redilatation. If you put a stent in a newborn, you have to understand what can be dilated. Cook's formula stent available from 6 to 12 can be dilated to 1.5 to 2 times. Cook's formula stent, a good stent, can be used. Adult auto size is 18 to 20 mm. But in a newborn, you can't put 12 mm. That's why if you put a 6 mm stent, it will go up to 12. But adult auto size you may not achieve. Then in future, you may break this stent and put a large stent, CP stent. But the stents may or may not break. It's not necessary you can break the stents. So large CP stent in previously implanted stents is a possibility, but not a surety. So this method of Cook's formula stent, putting a 8 mm stent, may not be a valid answer. Then biodegradable stents are under trial, mainly palliative, because they will degrade, and then again, if the recurrence happens, you have to do again the procedure. Growth stents, where you are having a two half of stents and circularly you are using the bioabsorbable part. So this covered stent, radial strength will go, but long-term stent will maintain. With age, the child grows, this will resolve, but this will stay. So you will, so stent may not impede the growth. 18-year follow-up is 18 months follow-up is available, and there is no growth restriction. This was 2004 study. Future studies are pending. This is another one very good stent, breakable stent. So this was called baby stent. What they did was they had a particular special patented design. Hook and eye connection, like hook and eye connections, which can be easily broken like this. So after a particular diameter, they will break out and they will allow a further growth. So this available and the can have go through 4 French sheath, pre-mounted stand, 6 mm by 20 mm balloon is available with this. Stand is 15 mm long and diameter can be adjusted up to 12 mm by balloon dilatation alone. If you go above balloon, about 12 in older age group, if you want to go above 12, this will break out. Opens up, sacrifice the radial support, and that will allow the unrestricted growth. So in a newborn, you put a stent of 6 mm. After 2 years, you put dilator up to 10 mm, and then in 10 years age group, you break this. That is the understanding of breakable stent. Few studies, the case studies are going on. So this is the first follow-up of the stent in 2018, and they found all 17 cases have successful deployment. Follow-up is up to 7 years. Redilatation have been performed till now up to 2.5 times. No major complications till now. So in a newborn, you can go up to 0.24 French sheath, 2 mm to 6 mm. In older age group, 5 to 8 mm. And in older children, you can break this stent to make it up to 12 24 mm. So up to 18 is easily achievable with this stent. This is Renata Medical's minimum stent. I have not used it, but it's not available in India. It's available outside, but this may be in future this may be available soon. So summarizing, we have various access routes available. Personally, in newborns, we favor axillary route. Balloon sizing is critical step. Don't oversize RT to be preserved, aggressive management, periodic with thrombolysis, growing stents may be a future. Thank you for this listening. If any questions are there, I would be happy to answer. So I don't see any